Good evening, everyone. Thank you for joining us tonight. Yet another medical update, part of Chris O'Brien Lifehouse CPD series on neurology, headaches, and migraines. And I would like to introduce our facilitator and chair for this meeting, Dr. Edmund Lee, Inner West Advisory Committee GP. Thank you, Edmund.
Thank you, Lydia. So yes, welcome everyone to our webinar. Tonight, the talk is an update on migraine and headaches. And our speaker is obviously very popular. Her name, she is Associate Professor Miriam Welgampola. She's a staff neurologist at RPA Hospital, specializing in vertigo and balance disorders. Her research is dedicated to early diagnosis and treatment of vertigo in the emergency room and primary care. Miriam's laboratory focuses on development of event monitors that capture vertigo attacks in patients' home, telehealth neurology, treatment of intractable benign positional vertigo by mechanical repositioning and the use of artificial intelligence as a diagnostic tool. So it will be a very interesting talk tonight. So Miriam, thank you.
Thank you so much, Edmund. I'm just going to share my screen. Just bear with me. Optimize sound. Yeah. Okay. So I hope you can hear me fairly clearly. Okay. Okay. So Lydia tells me there's an epidemic of headache just following the eclipse. And consequently, I hope my talk will be very topical for you. And these are the objectives that I was given by most of you, and I'll try to stick to them. As you know, headache is so common. I'm not a headache expert. I'm a vertigo person, but I happen to run the neuroambulatory care at the public hospital, and headache is our top presentation, followed by tremors and numb hands and feet. So headaches come with many different possibilities, and it's really useful to have a very systematic approach to headache. So I stole these pictures from the website of the International Headache Society, which is a place that I visit quite often. And they basically look at headaches as 4 broad groups. And the most common group is primary headaches, which are the ones that you and I commonly encounter. And these primary headaches, I'd like to call nice headaches because they're fairly well defined. They have their own pathomechanism, for example, migraine, tension headache, and cluster headache. Then there are the naughty headaches. These are the ones that keep us awake and worrying about the patient. So examples are the headache of meningitis, the headache of cancer, the headaches of medication overuse. These are the secondary headaches. Then you have things like facial pain, neuropathies, trigeminal neuralgias, not so common. We don't encounter them too often. We won't be spending too much time on them. And just to make it interesting, there are the silly headaches. The most common silly headache that I have encountered is the space headache, one that people talk about as a consequence of being in outer space. But again, we won't talk about that. So, primary headaches. There are 4 broad groups: migraine, tension headache. Then there's a really interesting one, which is we call them the TACs, trigeminal autonomic cephalalgia. These are headaches that are associated with a lot of autonomic phenomena like tearing and a runny nose on one side of the head. And then there are other unusual and bizarre headaches like headaches associated with sex. Secondary headaches are the more alarming ones. So, unlike our other neurological disorders, headaches rely so much on history. Okay, We use our lab tests to diagnose the secondary headache disorders, like, for example, meningitis or tumors. But really, to diagnose every single headache, you need a good history. So it is correct that it's nice to get your patient to give their whole story from top to bottom and to have an open-ended history style, but there are some tick boxes that you have to click, and these are the tick boxes. There are 9 questions. Okay. Onset, location, severity, quality, duration, frequency, what makes it worse, what are the associated phenomena, are there any systemic symptoms? So, you know, I spent a bit of time last night trying to find a nice mnemonic for you. There's actually a spot on Google that's a mnemonic creator, but all the things that they gave me were so ridiculous. And anyway, it's close to dinner time, so I made my own mnemonic, and it says, "Oh, lovely squishy quinoa, deep fried eggs and sausages." Okay. Onset, location, severity, quality, duration of the headache, frequency, what makes it worse, associated features, and systemic features. So, why is it important? I hope you can see this slide fairly well. Why is onset important? Because if you have a first headache over the age of 50, you'd want to image the person. If you have a sudden onset of headache, like a hammer at the back of the head, you'd be worried about a subarachnoid hemorrhage. You'd want to image them, send them to hospital. So the onset is important. Location gives you many useful diagnostic clues. So there are 2 headaches that are one-sided. Migraine is often one-sided, and those trigeminal autonomic cephalalgias are also one-sided because you get one-sided tearing, one-sided runny nose. Severity is a very useful clue. So tension headaches are usually mild. On the other hand, migraines are moderate to severe, and right at the other end of the spectrum, cluster headache is the worst human pain ever, and they will say this is worse than childbirth. Okay. The quality of the headache is useful. So migraine is typically a throbbing headache. Tension is a kind of a bandage-like headache, vice-like. And then trigeminal autonomic cephalalgias, also known as SUNCT, are stabbing headaches like an ice pick headache. So headache duration can be useful. The Headache Society says that migraine headaches are typically untreated between 4 hours and 3 days. Tension headaches can last for days and days. Cluster headaches will last minutes to 1 hour. So it is useful to ask, what's the duration? I typically would ask, what's the shortest and what's the longest duration of your headache? What about frequency? With both migraine and tension headaches, the frequency doesn't give you any diagnostic information because it can be so variable. It can be every day, or it can be once a year, and that doesn't give you any diagnostic information. But in the case of cluster headache, you do get very clear diagnostic information because there will be more than 1 headache per day. And typically the headaches will be seasonal. They'll say, well, typically the same time of the year. Okay. And then your autonomic headaches will be multiple times a day. Exacerbating features can be very helpful. We all know that if you get a headache on coughing and sneezing or ducking down, that's a high pressure headache. If you get a headache that's worse on standing up, that's a low pressure headache. If you get a headache every time you pick up that glass of red wine, it may well be migraine or cluster. And then there are benign and not so benign headaches that are related to sex. associated phenomena are useful, especially in the context of migraine. So, for example, migraine headaches are associated with photophobia, phonophobia, and nausea. Your trigeminal autonomic headaches are associated with a big red eye, a tearing eye, and a drippy nose, and a sweaty face. Okay. Also, giant cell arteritis, a feared secondary headache, is associated with jaw claudication, shoulder pain, and large joint pains. And of course, we know that systemic features like fever and weight loss will always alert us to some kind of systemic illness or even an undiagnosed tumor. Please interrupt me if you have any questions. So when I do take the headache history, I try to ask the patient about what kind of job they do, what's their mood been like, has something happened recently, do they sleep well, how much time do they spend at the screen, do they eat well, drink well, have they recently started a diet, how much exercise do they do, and are they on any medications, have any medications been withdrawn. So next, having completed the history, we go on to the examination. As part of your cranial nerve examination, it's nice to be able to do fundoscopy, but you might not have the time to. It is really important to do your visual fields, and the most important aspects of your cranial nerve exam after the visual fields is looking for Horner's syndrome, doing your pupillary reflexes, and looking for a facial asymmetry. A quick screening limb exam for a drift and gait is important. And other things that are important are to palpate the temporal arteries. And if the history is of occipital radiating to frontal headache, it's worth palpating the greater occipital nerves. Of course, it's important to do the blood pressure. When I see someone with headache for the first time, I would request basic blood tests like a full blood count, blood sugar levels, iron studies, and of course an ESR, especially in the elderly. Imaging if it is a new headache, if it is likely to be a systemic headache, or if there is an underlying history of a cancer. Most often the patients that we see in outpatient clinics would come with a set of screening blood tests done by people like yourself. So I would not require to do them. So now we are going on to talk about the common primary headache syndromes, and I just want to spend a fair amount of time talking about migraine because it is so common and so disabling. So as per the International Headache Society criteria, migraine is an episodic headache. It lasts between 4 hours to 3 days. And to diagnose migraine, you have to have two of the following. Has to be one-sided, throbbing, moderate to severe in intensity, and worsen with moderate exercise, like, for example, climbing stairs. And then in addition to that, you need at least one of the following: associated nausea or vomiting, or associated photophobia or phonophobia. So that constitutes the International Headache Society criteria for migraine. That's the full works, but really it's exactly as I summarized before. So how common is migraine? Apparently, 1 in 4 households will have a migraine sufferer. And in our household of 3 out of 3 have migraines. 20% of women suffer from migraine in our community, and about 6 to 7% of men. Interestingly, 10% of kids. Okay. I do see a lot of children in outpatient clinics. So as you know, the headache has a beginning, an aura, a headache face, and an aftermath. And this is just, I'm not going to go through this slide in great detail, but you know, when I was growing up, I was taught that migraine is a vascular headache and that the arteries constrict and then the arteries dilate, and that's all there is to it. But now we know that migraine is really a huge interaction between pain receptors in your meninges and in your arteries, multiple cortical centers, multiple brainstem centers, the spinal cord and the cervical spine. So it's really important to know that there is this powerful interaction between all these sites, because there are so many places that could act as triggers and so many targets for us to look at when we are devising medications. So with that in mind, let's start with the prodrome. During the prodrome, often people will have food cravings. They will have light sensitivity, sound sensitivity, lots of yawning, and sometimes they'll get a neck pain. And what happens during this prodrome is that the hypothalamus and multiple brainstem centers, just highlighted them in pink, and some cortical areas get activated. Then after that comes your aura. Now, many people who get migraine get a little bit of visual blurring. That's not an aura. What I mean by aura is a distinct neurological syndrome. For example, sparkling lights in a C shape, hemianopia, speech disturbance, one-sided facial numbness, one-sided hemi-body numbness. And again, when I was growing up, I was taught that what happens during the aura is that there is vasoconstriction. But more recent research has shown that there's actually a combination of hyperperfusion followed by hypoperfusion that we call cortical spreading depression. So phase number 3 is, of course, the headache phase. And the headache phase is actually this phase during which all those pain centers are hypersensitized. And these could be the meninges, the vascular structures, and these. So it's really a sort of a neurochemical event that you have sensitization of the brain leading to throbbing pain. And it can be one side of the head, or it can be bitemporal. There will also be nausea, vomiting, sensitivity to light and sound and smells during the headache. And then finally, when this headache of hours to days is finished, you will have hypoperfusion that is left over. And during this period, the patient will just feel like they're hungover. Okay, so the headache's gone, but they just feel like they've been wrung in the washing machine. So I'm going to start with a case. This is actually a colleague, 32-year-old researcher. She gives a 3-year history of retroorbital and frontal and temporal throbbing headaches. The headaches are moderate in intensity, but she can push through them. She comes to work in spite of them. And they are quite frequent, 2 to 3 times a week. And they last all day when she gets them. If she's lucky, she might end up with a couple of hours headache. There's nausea, there's photophobia, and she sits down at her computer to fill up a spreadsheet, and that seems to trigger it. She loves having a glass of wine after work, and that makes it worse. And she also finds that on the day before her menses and the first 2 days of her menses, she will have a particularly bad headache. At work, there's continuous fighting because she has to turn down the lights and everyone else wants them turned back up. So I examine her. She has a normal exam. She's come with a set of bloods. These are normal. I tell her, look, this sounds like migraine without aura. I'm going to organize an MRI scan, and I'm going to advise you on some emergency drugs. Why don't you carry Aspro Clear with you and take 2 Aspro Clear with a little cereal bar as soon as you feel the headache coming on. So she's very young. She's only 32, and I think you've never had a preventer. Your headache frequency is so high that you would definitely warrant a preventer. So if it's anything more than once a fortnight, you've got to seriously think about a preventer. So I offer her riboflavin 400 milligrams and equivalent magnesium 300 milligrams. And I advise her, you've got to be a human sponge. You've got to drink lots of fluid. Please eat 3 meals a day and forget about that diet. Take a screen break every half an hour. Get up from your screen and have a little stretch. Ensure that you exercise. Do gentle exercise. And that is a typo. Make sure you protect your sleep, at least 6 to 8 hours of sleep. Okay. So, returns, comes back to see me in about 3 months. The MRI scan is normal. About 60% of people do respond to riboflavin, but this particular lady doesn't. So she said, no, nothing happened. Maybe I feel a tiny bit better, but I'm just suffering. So this kind of person is at serious risk of getting into a medication overuse headache because they're taking painkillers 2 or 3 times a week. And if I don't do something quickly, they're going to turn into a chronic headache and they're going to be dependent on aspirin, Imigran, Nurofen, paracetamol, and the headache's going to be a daily headache. So I convince her to start amitriptyline 10 milligrams at night. And I also teach her to double it in about 2 weeks' time and to see me again in about 3 months. I think I've missed a slide. So somewhere there, I've missed a slide. She comes back on 25 milligrams of amitriptyline. And she doesn't like it because it makes her sleepy. She doesn't like it because she's also put on a significant amount of weight. And so we agree that perhaps amitriptyline is not the right drug for her. I do try to give the amitriptyline a little earlier on in the evening to see if she'll tolerate it a little bit better. But it doesn't seem to work, so we switch to a second migraine preventative. I still keep the amitriptyline going and introduce a tiny dose of Topamax. I usually start with half a tablet BD, so 12.5 BD, and slowly increase it. Okay. So now she sees me in another 3 months. This time she's on Topamax 50 milligrams twice a day. Fantastic response. Really happy because she's lost a little bit of weight as well, but unhappy because it seems to be affecting her mood. And at that point, I say, look, let's just start bringing it down. Let's see whether we can reach that sweet spot where you're not depressed, but it's giving you decent headache relief. So comes back in 3 months looking fantastic. She's lost a bit of weight. She feels well, so she has begun to exercise. But the most important intervention she feels is that she stopped eating takeaway every day. She started cooking for herself. So no preservatives in food, only natural products. Also changed her job, also changed her partner. She's really happy, drinking lots of fluid, now happy to come down to Topamax 25 milligrams BD and says, well, I don't think I need you anymore. I'm happy to see you on demand. And we agree that if all is well, around the 6-month mark, she might want to wean herself off medication if everything's going well. So I might just stop for a little and take some questions. Edmund.
Yeah, so there are quite a few questions, but there are some related to the case that you just mentioned. So, some mentioned that, well, the cervicogenic headaches could be her work posture, ergonomics. So I suppose yes.
Absolutely. Very, very important point. Yeah. It's really fully worthwhile getting, I mean, most people will tell you that the chair they use is not satisfactory, or that they adopt a particular position when they're on the screen. And the most common thing that people will tell me is that I spend about 3, 4, 5 hours at my desk and I forget to take a break. I would only take a break when I'm thirsty. Yeah. So very true, very, very important. But here's the thing, cervicogenic headache. We mustn't forget that cervical pain can be a trigger for migraine. So when you treat that neck, you're actually taking away the biggest trigger. And yeah, it is a very important approach.
Yeah.
But
So, yeah,
go on.
So someone also mentioned that why will you be concerned with someone on paracetamol regularly?
That is a very, very important question. Thank you so much. So if someone has to take paracetamol or Nurofen or Imigran more than twice a week, they are at extremely high risk of developing what we call an analgesic overuse headache. So it will, within months, evolve into a chronic daily headache. So if they are needing paracetamol twice a week, we have to break the cycle with a preventer. So it is safer to have a preventer than to have paracetamol daily. So it's really, really important to get in there and say, we've got to break this analgesic habit, and I'm going to help you out here. Whenever possible, let's do our best to use a natural ingredient like vitamin B2, truckloads of magnesium, throw in some coenzyme Q and feverfew, but it's really important to get in there and get into the tradition of the preventer.
Also a question, do you use headache diaries?
Yes. So what we do is, so as you know, Paul Spira, who passed away recently, is the father of the headache diary that is widely used in Australia. So what we do is to give the patient, or get the patient to print out a calendar. We get them to encircle the headache days and to underline the menstrual cycle days, the period days. And yes, it is very useful. Now, an interesting thing is, it's very counterproductive to ask your patient with vestibular migraine to keep a diary because they get hooked on it. But interesting, the headache patients don't. They really don't like talking too much about their headaches. So yes, a headache diary is very, very helpful. It'll give you a thumbnail sketch of the headache pattern. Any more questions?
There are quite a few, but I think maybe you should just continue with your talk first.
Okay.
Some of the other questions are related to what you've been talking about. So,
okay. All
yeah,
right.
there's some very early questions. Even when we first started, already questions went up. So yeah, I think maybe you should just continue your talk and do all those questions at the end.
Yeah.
Okay.
So I'm just mindful that it's 7:30 and it's time for you to have a big stretch, get up from your seats, because too much screen time can give you a headache. So headache treatment, I usually tell my patients this has 3 arms. I'm going to help you in 3 different ways. Number 1, rescue medications. Okay. And that's your paracetamol, your Asproclear, and your Imigran. I get them to always carry it on their person. If they carry a wallet, it goes in their wallet with usually a small piece of food like half a cereal bar. And if they don't have a purse, most modern people don't, I ask them to carry it at the back of their smartphone. Then there's preventative therapies, and we will be talking about them. These can range from supplements to more complex medications. And then there is the lifestyle interventions, which includes keeping a diary, avoiding triggers, and making sure you eat well, sleep well, exercise well, drink copious amounts of fluid, and take multiple screen breaks if your job involves a computer. Last of all is manage what makes migraine worse. These are sort of big picture kind of interventions, like thinking about your job, thinking about the way you live your life. I don't interfere, but I do just float the idea. Okay. So behavioral factors, it's important to think about managing depression, managing anxiety and stress, maintaining a good sleep routine, a consistent daily schedule, and also making sure that people have a structured approach to their medication and know to carry their rescue drugs, know what their preventatives are, and stick to them. It's really interesting how much relaxation therapies and cognitive behavioral therapies can contribute. There is not much clinical trial data on these techniques, but there's a great deal of anecdotal evidence that these techniques do help. With regards to diet, I like to tread the middle path. As you know, in the United States, they are very rigid about migraine diets. Over here, people really enjoy their food, so we don't want to deprive them. So I typically tell people, with regards to caffeine, you can have your morning coffee, but try not to exceed 2 cups. Okay, make sure you have breakfast, lunch, and dinner, and snacks are encouraged. I do let them have a glass of red wine if they're passing out for it, but I also tell them, try to discover what is the most friendly type of alcohol for you, because there are some patients who will say, just the red wine sets me off, but perhaps champagne or beer won't. So I do encourage them to try and discover what kind of alcohol can you have. And of course, drink water all the time. So diagnose the headache, offer rescue remedies, specific therapy, and lifestyle advice. So I think we talked about all of them. It's really important to tell patients that they should have realistic expectations. So whatever preventer that you give them, on average, I would say that a positive clinical trial is one where 50% of people have 50% improvement. So that is not a perfect result. So it is more a disease-modifying treatment rather than a complete preventer. I give them a script for rescue medications for simple things like Asproclear, paracetamol, Nurofen, and then sumatriptan, naratriptan, elatriptan, one of those for severe headache. People usually learn to have a stratified approach. They learn to identify a mild headache and take the mild agents for them. And sometimes they can't tell. And if they can't tell, I do encourage them to hit it hard, especially if the headaches are not too frequent. Indicators for a preventative. If there are 2 to 3, I would say moderate to severe headache days per month, or 6 to 8, any, including mild, that the patients would perceive to be not migraine headaches. Remember that there are some contraindications to triptans, especially heart disease. There are some times when headaches are really infrequent, but people get so terrified of them that you do offer a preventer. So, and particularly if there's a brainstem aura, if there's powerful bilateral tinnitus and vertigo, or if there's headaches with hemiplegia, then in that context, they will agree to have a preventer because the whole headache syndrome is so terrifying. We talked about this, that patients can be at risk of developing medication overuse headache. Therefore, it's really important to say your emergency drugs are for emergency use. And if you're using them more often than twice a week, you've got to alert me, because it means that we have to work harder on the preventers. So these are some examples of preventative therapies that we use in clinic. We always start by offering the patient natural products, magnesium, riboflavin, feverfew, and coenzyme Q. And as you know, there are a couple of compound products. There's one called Migraine Care, made by Bioceuticals. There is an American product that is called MIG Relief, and they both have this combination. Sando Migraine is available in Australia, but not in the US. Amitriptyline and dothiopiin, tricyclics. Very useful if the patient has neck pain. Propranolol, I would use mainly if the patient also has high blood pressure. Verapamil, also if the patient has high blood pressure. Lamotrigine is fantastic if the patient happens to have a concurrent mood disturbance. Topiramate, especially in the context of obesity, but many of us end up using Topamax because it's a very powerful drug. So it is about third line for me. Cybelium is exceedingly rarely used. It's a calcium antagonist. It's widely used in the US, but here in Australia, it's an authority drug. It would be the final port of call for our clinic before we go on to Botox and to the anti-CGRP antibodies. So I will be giving you this PowerPoint presentation. These are the ranges of doses. Okay, and as you can see, so level A evidence means that there have been more than one trial that indicates that they are efficacious. So just make note that topiramate does have level A evidence, whereas amitriptyline, although it is a hot favorite, has only level B evidence. Okay. There's a whole range of preventatives and a whole range of doses, but the most widely used drug in Australia, the most widely used prescription drug, happens to be amitriptyline, starting at a dose of about 10 milligrams. We always ask our patients to take it about 3 hours before bedtime. We warn them about sleepiness. We warn them about dry mouth and about the propensity to put on weight. Not all of the patients put on weight. Very rarely they will also get constipation, but that too is not a common side effect. So I just want to spend just a tiny amount of time talking about which of these we get to use in pregnancy, because I do look after quite a few young mothers, and paracetamol is our absolute go-to as an emergency drug. Non-steroidals can be used, but it's only from the second trimester to week 30. Because it can cause problems with the premature closure of the ductus arteriosus and bleeding. So it's only a short window. Sumatriptan can be used, but the two drugs that we widely use with confidence are paracetamol and Stemetil, okay, in the context of a pregnant mom. As you know, 70% of pregnant moms will experience an improvement in their migraine, but then the other 30% will be suffering. And the most widely used emergency drugs would be simply paracetamol and Stemetil. What about preventers? we do our best to make do without preventers, but there are instances when we have to. These are the agents that were recommended as usable with caution, but I've highlighted the ones that I personally have experience using, and they are amitriptyline and propranolol. And these two are the drugs for which there is Australian experience using them in pregnant mums. Amitriptyline is the most widely used agent, and Mothercare approves the use of it, and in fact they encourage us to use it rather than spending excessive time with natural products if the mother is suffering. We do start off with high dose magnesium and very low dose vitamin B2 in the context of mums who have worsening of migraine headaches during pregnancy, but there have been a few instances when we've upgraded them to amitriptyline. So there are some drugs that we use in adults for which there's no safety data in pregnancy. That's cinnarizine and flunarizine. Drugs that are unsafe in pregnancy are Topamax, sodium valproate, and venlafaxine. Sleep is super important, and migraine sufferers who just manage to improve their sleep by more than 6 hours will notice that there's a significant improvement in their attack frequency and severity. And we do ask them to pay a lot of attention to lighting, temperature, making sure that they have heaps of fluids, regular meals, and limit caffeine. This is just quick slide on the doses of the nutraceuticals that we use. If it is magnesium citrate, it's 400 to 600 milligrams. If it's magnesium glycinate, it is 500 to 1,500 milligrams. Vitamin B2, 400 milligrams. So these two, magnesium and vitamin B2, are the two most commonly used nutraceuticals in the context of migraine preventative therapy. I might just skip those slides in the interest of moving on. It's really important to give the patient modest expectations, because I often tell them drugs are like mini poisons. You could get very lucky, but you might be waiting a long time before it works. You try to profile the patient, beta blockers for the hypertensive or anxious people, pizotifen for people who have poor appetite, or if they have a lot of nausea, tricyclics for those with back pain or neck pain, topiramate for those with sleep apnea and obesity, and epilim and lamotrigine for those with mood disturbance. As I said before, flunarizine when everything else fails. Typically, it's useful to try each drug for 2 months on full dose. And once you've had a good run, and if you've had a good result, do float the fact that you could consider tapering the medication, because you may very well have broken the cycle of migraine. Some patients who are on relatively harmless drugs, such as, for example, a tricyclic antidepressant, will tell me, no, I'm not coming off the drug. This is a very difficult time in my life. And I always listen, but I try to remind them approximately once a year to say, are you ready to come off your medication? Okay. Botulinum toxin is recommended after 3 or more preventatives have failed, and also in patients who are unable to tolerate oral preventers. So the new kid on the block is the anti-CGRP antibodies. So CGRP is a peptide that is released during the course of migraines. And the anti-CGRP monoclonal antibodies are now, as you know, PBS approved for chronic migraines with over 15 headache days a month. But there is research evidence that they're helpful in episodic migraines, but the patient will have to fund it themselves in that case. Okay. So just a little bit more about anti-CGRP antibodies. Sorry, I will. Basically, it's a 37 amino acid neuropeptide, and it is widely expressed throughout the central nervous system and the peripheral nervous system. It's a vasodilator, so you've just got to be careful not to offer it to someone with ischemic heart disease. Those patients were excluded from the clinical trials, those with ischemic heart disease and those with stroke. During a migraine attack, CGRP levels rise, so naturally the anti-CGRP antibodies are targeting, these are the first drugs to actually target the process of migraine. Everything else is borrowed from epilepsy, from depression, but the anti-CGRP antibodies are the first drugs to actually trigger the to address the mechanisms of migraines. So that slide says the same thing. There are 4 available anti-CGRP antibodies: Emgality, Ajovy, Aimovig, and Vyepti. And as most of you know, at various points in time, we've faced a national shortage of these drugs. So we try to be very careful in this interim period before offering our patients these drugs, for the simple reason that those patients who desperately need it will not have access to it. So in the hospital, we strictly follow the rule that they have to have failed not just 3 drugs, but multiple medications that you believe would have otherwise worked for them. So people who have had multiple failures would go on to have a monoclonal antibody. So for example, in my clinic, I would only have about 10 patients who are on these. People like Ron Grano or Bronwyn Jenkins, who see exclusively difficult, intractable headaches, would have hundreds of these patients. But in our public clinic, we would have about each of us would have about between 10 and 20 patients who are on a monoclonal antibody. So small numbers. The wonderful thing about these drugs is that they are tolerated so well. So we are really very optimistic about the future. And I do hope the expense of the medications will drop and the availability will increase. So they can cause a little bit of reaction at the injection site, a little bit of hypersensitivity, but the Aimovig can cause hypertension and constipation. But overall, compared with the old-fashioned drugs, these new medications are tolerated remarkably well. Any questions?
Yes.
Edmund.
Yes, right. So there are quite a few, as I said, but some, as your talk has already answered. There are ones related to Botox. I think someone asked who does them and where do you put the Botox in? Which site of the body do you use the Botox?
So sadly, at our PA hospital, we don't have an on-site Botox expert. We do send them outside. There's Dr. Paul Darvineza at St. Vincent's Hospital, and then Dr. Caitlin Parat's group at Sharp Neurology also offers Botox. And in Bondi, I know that Ron Grano does Botox as well. So we don't have an in-hospital Botox expert for migraine headache, and that's a deficiency. Typically, they would be injected around the frontalis muscles and muscles around the scalp and the neck. I can't tell you the specific doses. Just as an aside, recently we had the experience of using Botox in the situation of pregnancy, It was an uncommon use, but it can be given in intractable headaches in pregnancy as well.
Yep. So for someone asked about aspirin, so taking 300, taking up to 3 aspirin as a
Yes.
first headache. Yep. So that works for most migraines. What about caffeine?
So, as you know, caffeine withdrawal is the culprit. And people who consume more than 2 or 3 cups of coffee a day are more likely to trigger a headache. So we don't look upon caffeine as a culprit. We encourage people to just have that first cup of coffee. But if you were asking about the combination of paracetamol and caffeine, aspirin and caffeine, yes, it is a good option as long as it is used. It is not overused. It's just as long as you don't exceed twice a week or 2 or 3 times a week, because then again you get into this analgesic overuse pattern.
Okay, good. So we'll go back to the top of the list then. The first question we got was someone with migraine with aura. Is oral contraceptive pills contraindicated? And does it matter what brand of oral contraceptive pills? And what about the history of migraine? If it's in the past, is that still contraindicated?
Look, if it is a convincing history of migraine with aura, the advice of the International Headache Society is to avoid estrogen-containing oral contraceptives. So you can offer them the progesterone-only pill, but estrogen-containing oral contraceptives are contraindicated. The other thing is you can offer other types of contraception, non-pharmacological methods of contraception, but yes, because although the risk of a stroke is small, it is approximately 3-fold when you have a migraine with aura. Have to make sure that it is truly an aura, so sparkling lights, scintillating scotomas, speech disturbance, numbness, rather than the transient visual blurring that everyone gets. Also, getting vertigo with migraine is not an aura. It's just such a common manifestation. So just getting transient blurring doesn't count. Getting dizzy doesn't count as an aura. It's the typical sparkling lights, facial numbness, speech disturbance.
Okay. So another question is on MRI, the changes. So does migraine cause the T2 hyperintensity white matter lesion on MRI?
It is said to cause this. And, you know, this is something that both you and I have sleepless nights over, right? We see the young person who's 35 years old and they've had 3 migraine headaches every week for the last 10 years. And yes, they've got a head full of white matter hyperintensities. And the radiologist kindly points out, yes, you do see this in migraine. If it is disproportionate to the patient's age, I would do at least 1 more scan in 12 months' time. But then I've been many, many times in the situation where the scan is exactly the same. We are reassured and we just move on to simply treating the migraine. Yeah. So yes, we do see it.
Is there other causes for those changes? I mean, cardiovascular?
So, of course, there would be hypertension, hyperlipidemia, smoking. It is worth, if it's very disproportionate, it's worth looking for vasculopathies by doing your vasculitis markers. But my experience is that I do vasculitis markers in these people and it uniformly comes back negative. Hardly ever do we get a positive result. But yes, it's good to go through the process of doing your vasculitis markers and advising the patient on cardiovascular risk factors. But there will be young people who have 0 cardiovascular risk factors who still have quite dramatic white matter hyperintensities. Fortunately, generally you can tell them apart from multiple sclerosis because they are not periventricular. They are relatively peripheral. but still you do worry about them. And I tend to do a progress MRI in about 12 months' time.
Okay, so there's a question about nystagmus and vertigo. I have to say I don't understand the full question, but basically I think what the question is asking is someone with wakes up in the middle of the night with nystagmus and vertigo, and then also gets up in the morning feeling nauseated and also with the dizziness. Is this a type of migraine?
So you have to be very specific. You see, if I get up from my bed with vertigo, sure, it could be a migraine, but don't forget benign positional vertigo. So in anyone who wakes up, if it's a wake-up vertigo, the top diagnosis still should be BPV, and it's really important to do that whole pike test and make sure that you don't see paroxysmal positional nystagmus, and if you do see that, to do an Epley maneuver. So I'd say when I get that history, I woke up with vertigo, 9 times out of 10, it's going to be a BPV rather than a migraine. One little clue is if they say, today I woke up with vertigo, but tomorrow, the day after, I didn't wake up with it, it was just a one-off wake up vertigo, then it's highly likely to be a migraine-related vertigo, because unless someone treated the BPV, it would recur for several days on going back to bed.
Yeah. So a question on preventers. So how long do you keep them on it before you go on to the next one?
So minimum 2 months on full dose. And if they say nothing's happened, then I would wean off the one while introducing the other. But I would really try to convince them to keep going for a period of about 2 months. Especially the natural products, they take about 2 to 3 months to kick in. And often they themselves will write back to you and say, actually, I don't need to do that follow-up. It's started getting better, and I don't need to come back.
Okay, so there's a question on the evidence for natural therapies. Now, the person, Casey, didn't actually specify what she mean by natural therapies, but what do you think?
I think you mean, I'll just go a few slides back. The evidence for some is good, for others is not good. So have a look here. Riboflavin, moderate to strong evidence. Magnesium, strong evidence. Feverfew, not really. And coenzyme Q, not really. Okay, so the two that we actively promote are riboflavin and magnesium, but there's also something else there. You see, it's quite possible that what you might be dealing with is the patient implementing some really important lifestyle changes, and you're giving them time to do that. And so therefore, it's important to try something relatively gentle and harmless while they're implementing their lifestyle changes. So often I don't know whether it is because the person started eating, drinking, sleeping properly, or whether it's the vitamin B2 and magnesium. But a majority of our cohort in the RPA neuroambulatory care would just get that, and they'd come back in 3 months and they'd say, not too bad, actually. You might want to leave me alone. And especially the younger people who are quite averse to taking medications, and that's a good thing. They'd often say, no, I just think I'm making do, and thanks.
Yeah. So a question on whether you refer to physiotherapists for cervicogenic headaches.
So I would say if there is a headache with a significant neck pain, I really don't, I often have difficulty with this distinction between cervicogenic headaches and migraine. And if you dig deep into the history, there will be the International Headache Society criteria, somewhere they're being fulfilled. It'll be a moderate to severe headache. It'll be a headache with nausea, and there'll be really cracking neck pain. So you treat the headache on its merits, but yes, you would send them to a trusted physiotherapist. Almost never to a chiropractor. And there are some groups of physiotherapists who are particularly skilled with treating these patients, especially in the younger patients who are happy to just hold off on medication. It's definitely worth trialing. Yeah. I would also sometimes, if there's a powerful neck pain component, would image and try physiotherapy first, try the tricyclic antidepressants, and then also try epidural nerve root sheath injections. And a combination of one or more of these might be successful in controlling the headache. So it's 8 o'clock. Don't forget to have a nice stretch. Take your eyes away from the screen. We are having a screen break. Okay.
Okay, next question. So, do you want to go on with your talk, or are you happy to continue?
No, happy to continue with the questions.
Okay, so can GP prescribe CGRP antibodies?
At the moment, I think it needs one of us to get started, but the GP can continue. And the other thing is you can't do Botox and the anti-CGRP at the same time. So the first script, the initial script, can be started by the general practitioner, but my take on it is that the subsequent scripts can be given by the general practitioner. We've had a lot of trouble getting the same anti-CGRP antibodies prescribed, mainly because at different times, different pharmacies and different locations run short of the product. And that's part of the reason why we're being so abstemious. I think they're wonderful drugs, but I just hate the thought of the patients, the people who really need it, running out of it. So when that problem has been solved, I think there will be wider use.
Okay. So using a triptan to stop an attack, if it doesn't work the first tablet, do you repeat it, and how long afterwards?
With sumatriptan, you can repeat it in about an hour's time. Yeah. So you would give 50 milligrams, and then you would give a second one in about 1 hour. There's another situation where I would give the triptan twice, that is in people with the menstrual headache, where they often preempt the premenstrual headache, and they would use naratriptan twice. Yeah.
Okay, so someone asked whether, so if you can't, well, I think you don't like using Stemetil for vestibular migraine. So the question would say, oh, okay, what should the GP do?
So vestibular migraine treatment is very much like migraine headache treatment. Number one, you treat the urgent episode. There are two things you can give ondansetron, and there's a new drug, Cisinate, that's available on the market. It's an Australian drug. It's a combination of cinarizine and dimenhydrinate. I don't have an objection to Stemetil, but just give them only something like enough to about 10 tablets, so that they will only use it when they're absolutely desperate. Now, with the Cisinate and the cinarizine, they will only use when they're desperate because the tablet is expensive. The problem with Stemetil is that it is very inexpensive. So many of them get hooked on the tablet. And, what I worry about is that 5 years down the track, they would have got into the habit of using it, and they would have developed drug-induced Parkinsonism. And I won't be around for them to blame me, but, I would have written that first script. This tends not to happen with the harder to find drugs because the patient just can't be bothered going looking for it. And they don't want to spend that much as well. So it's good to have that little restriction so they won't use it too much.
Okay, so someone mentioned that the Family Planning Association mentioned that if someone had migraine more than 5 years ago, then they can use oral contraceptive pill. So I don't know whether you can comment on that.
Migraine with aura, that's a difficult one. I suppose you can assume that it's gone back into remission. I don't know is the answer. I need to look it up. I don't know is the answer. In general, my practice has been, if it is migraine with aura, to avoid the OCP. I can get back to you though. I can look at the literature, whether there is safety literature. I honestly don't know. But my practice has been to be careful and to avoid it unless it is a migraine without aura, in which case you can use your low-dose estrogen pills.
So now this is a question from, is Remigepant available in Australia? And how is it?
I don't think so. I don't think the Gepants are available yet. Yeah, I haven't used them as yet. Yeah, so they are for acute headaches, but no, I haven't used them yet. We haven't. I don't think they're available as yet. So in a public hospital setting, I think we strictly go by what's available on the PBS. And thus far, the 3 drugs that have been available on the PBS have been galcanezumab, fremanezumab, and Vyepti. Vyepti is available as an infusion, and they're all 3 of them are preventers.
The question is, what are vasculitis markers? Rheumatoid factors or?
So anti-nuclear antibody, extractable nuclear antibody, rheumatoid factor, and double-stranded DNA if you're suspecting lupus, and ESI and CRP, of course. Yeah.
So there's a question, there's a question on vertigo. So vertigo patient had the nystagmus lasting hours and the headaches later. Does this change whether it is a benign positional vertigo?
So what matters is what happens when you put their head down. If they're sitting up and you're seeing the nystagmus, well, then that's not positional nystagmus, is it? If they're just sitting up and you've got them sitting on the bed and you see nystagmus, that's spontaneous nystagmus. It's not positional nystagmus. If they have a concurrent headache with it, yes, it's highly likely that it is vestibular migraine. If they have a headache later on in the day, it's still quite likely that it is vestibular migraine. But if they woke up with it and it's exclusively positional nystagmus, that's when you would think of BPV.
Okay. So question on B2, vitamin B2 and magnesium. So do you check the levels before you try them? And how does it work? How do they work in migraine?
So with the vitamin B2, it's believed that the body fluids of migraineurs, it's been demonstrated that the body fluids of migraineurs have low levels of vitamin B2. What the precise mechanism of action is, we don't know. Same with magnesium. But we do use both at high levels. They are fairly innocuous medications. Especially in children, we would use them in high doses without any adverse effects. So I agree that there's not a huge amount of evidence, but if you think about it, most of the other drugs we use as preventers have little evidence too, except for topiramate and the beta blockers. So for example, amitriptyline has modest evidence, but lots of anecdotal evidence.
So with triptans, are there difference between them? Which is more efficacious?
Look, it's a lot of individual variation. And for me, it doesn't seem to follow a logical pattern. So I tend to start with the most basic triptan, sumatriptan, but and if that doesn't work, I move along the line to use either Relpax or max salt wafers. If the headaches are particularly long, I use Naratriptan, which is Naramig. And if you are treating menstrual migraines, I do use Naratriptan twice a day on the expected days, and it's almost like a mini prophylaxis.
So question whether sumatriptan or aspirin is more effective.
It's this is the luck of the draw. For some people, aspirin will be more effective. So I just get them to try both. Just get them to try Asproclear for one headache, get them to try sumatriptan on a different day. They can try both if they wish, if the one hasn't worked. And then we get them to stick with whatever works best for them.
Okay. So any difference in migraine symptoms between men and women?
Mainly migraine prevalence, I think. Okay, so the guys, there'll be 7% of the guys. The girls, it's more like 3 times more common, 20 to 21%. I don't think there is a difference in the kind of migraine symptoms.
Okay. So is there acceptable migraine preventers in children, for children?
Okay, I'll tell you about the ones that I have experience using and the ones that are considered safe. Riboflavin is considered very safe at the maximum dose. Magnesium is considered safe. If they are an adult weight, so about 50K or more, we give them adult doses of all 4 agents, riboflavin, magnesium, coenzyme Q, and feverfew. They are considered safe. Propranolol, if the blood pressure doesn't cause any problems, if there isn't hypotension. And pizotifan, periactin. Those are the drugs that are used as preventatives. In general, having said that, I have to say in my entire career, I would have started about 3 children on prescription drugs. Most of the time, it would be just the vitamin B2 and the magnesium, and intermittent use of paracetamol with ondansetron.
Okay. All right. So this is a question on migraine that lasting more than a day. I think the question is they're asking that there is a visual disturbance that persists for 4 months. And the normal fluorescein angiogram, or should someone do a fluorescein angiogram? But then it's uncertain the cause and it resolved by itself. So I'm sorry, I couldn't understand this question. So maybe
I kind of think I know where you're coming from. It's a very vexing problem. It's, you know how I showed you those 4 kinds of headaches, the nice ones, the naughty ones, and the silly ones. This status aura is considered a very unusual variant of migraine, and there's very little knowledge or evidence about it. It's quite frightening when it happens, and I've only seen it once when one of our PA nurses had an aura for 3 days. It's very scary. We imaged them, and just like you said, we did all the vasculitis markers, ophthalmology assessment, and it vanished by itself. And post hoc, because nothing happened, the conclusion was that it was a migraine. But I would say this is an area of very little knowledge, and it is entirely reasonable to get a medical retina specialist, someone like Peter Hayden or Brian Harrisburg, actively involved to get imaging, get blood markers done, because this is a very, very unusual thing to have extremely prolonged visual symptoms, because it could be the beginnings of a vasculitis. Yeah, but obviously you did all the right things, fluorescein angiography, bloods, imaging, and it went away by itself. There is little knowledge about that, and it's a rare phenomenon, but it's worth thinking that it might be the beginnings of a vasculitis.
So someone with migraine during the periods, using an estrogen patch, would that help?
You have to be careful about the total amount of estrogen. The answer is yes, it would help. There are several ways that you can treat these people. First of all, you can give them mini prophylaxis. If they have a very regular period, you can predict the day they are going to have the period, and typically they will get the headache the day before. Okay, and you can plan to give them mini prophylaxis on the day before the period and the first 3 days or so of the period. So it might be an NSAID that works for them, or it would be nartriptan. That's one approach. The second approach you can try is, if they are not those patients with migraine with aura, you could elect to give them the sugar pill only about once every 4 months. So you are avoiding the period. And then the third approach is the estrogen patch during the period. Yeah. So it's there. Many patients will have the period exacerbation, and the 3 approaches are either mini prophylaxis, or less sugar pill and more period-free cycles on a low-dose oral contraceptive. I have less experience using the patch, but in theory, yes, the patch could help. But the easier approach is actually to have more cycles without the sugar pill.
Okay. Any contraindications to using a triptan?
Ischemic heart disease is the major contraindication because it is a vasodilator. So, in fact, I've had patients for whom chest tightness has been encountered, and then they've been investigated and they've turned out to have ischemic heart disease, and the immigrant has worked like a little stress test, I suppose. So that is the major contraindication.
Can melatonin be used in migraine?
I would advocate using melatonin in those people who have sleeping problems. And I would think that it'll reduce the frequency and severity of their migraine attacks because it's helping protect their sleep and their hours of sleep. Although not precisely as a migraine agent, it would be helping the cause of migraine.
Okay, so diet triggers for migraine. So cheese, wine, chocolate. Is this does it work for stopping the amines?
Look, perhaps it works, but what I can say is very few Australians will agree to it. I did my postdoc in the US, and I arrived in my first clinic, and I gave them the migraine diet sheet. And I still remember this gentleman taking one look at him and saying, "Get serious, kid. What do you think you're doing?" And I thought, he's very rude. And then after the second, the third, and the 10th patient said the same thing, I just threw away the diet sheet. After that, so it's a practical problem. And I've never had the opportunity of testing it out. Occasionally, you'll have just the one patient, maybe one a year, who will say, "Give me a migraine diet. I'll do whatever you say." And you gladly fish it out and say, "Here you go." It's a completely harmless thing to do. I tend to advise patients, just look out for things that trigger your headache and avoid those, because there's also a happiness factor. And for that reason, I think in this part of the world, the diet doesn't seem to work, mainly because people enjoy their food. So I've never had the opportunity of testing it out.
Okay, so question on Chiari malformation. Can that cause migraine?
Very good question. It can cause headaches that mimic migraine. Just once I've had I was actually going to show you that as a case, but I didn't. Patient who had what looked like occipital throbbing headaches. And she said one thing that was a little bit odd. She said, it gets worse when I laugh. Not when she coughs, not when she sneezes, not when she ducks her head down, but she said, every time I laugh, I get a big migraine. And she had the typical treatment, and we did the non-urgent MRI, and there was a massive Chiari malformation. It was to the extent that required decompression. Post-decompression, she still had some migraine headaches. So she and we both elected to continue her Topamax. But I just think that was not a migraine headache, that was the Chiari. But I had to see the scan to diagnose her. I didn't beforehand. So the answer is probably. It can give you a headache that you might mistake, but do look out for those pressure features, including a laughing headache.
Okay, so the diet triggers. Do you have the migraine diet sheet?
I do. I can send it to you. I would also recommend there's this fantastic book called Heal Your Headache by Dr. David Buchholz, Bucholz. He goes through he's an American neurologist, goes through the diet in great detail, but I still do keep the migraine diet, and I can certainly send it through Lydia.
Okay, that's good. Question on coffee. So it says if give strong coffee at the start of migraine, as coffee is a vasoconstrictor, so can that only be used early in the migraine, or it can be used later to stop the vasodilatation?
I think coffee can be used as a headache, an acute headache medication. I don't know what happens if you take it late. I would assume nothing exciting. I suppose you know there is also an entirely different kind of headache that we call the alarm clock headache. There are these people who wake up at 4 o'clock in the morning with a migraine headache, and the treatment for that is to have a strong cup of coffee at night so that your caffeine levels are maintained about the time that your headache kicks in. I do know that taking it early helps, but I honestly don't know what will happen if you take it halfway through.
Okay. Now, there's still a few questions, but I don't know whether you want to continue with your talk, and maybe Lydia can have these questions. If maybe you can answer these questions later in writing, and Lydia can send them out.
Okay, sure. Okay, all right. Maybe we will cover just one kind of headache, which is the tension type headache. Okay. So this is also another colleague who says, I'm a bandaged bear. She's 34, she's a nurse. 10-year history of a continuous bilateral headache. She feels like she's got a pressure bandage around her head. It's mild, 5 out of 10 severity. It's never throbbing. It's constant, vice-like, not associated with nausea, vomiting, photophobia, or phonophobia. It doesn't awake her at night. She takes Panadol once or twice a week. No pressure features like exacerbation on coughing, sneezing. Menstruation doesn't seem to affect it. She's a very good girl. She doesn't smoke, doesn't drink coffee, and there isn't a family history of headache. So her MRI, her non-urgent MRI brain was normal, and we diagnosed her with a chronic tension type headache. And obviously, it's really important to focus on lifestyle measures, relaxation, hydration, good quality meals, exercise, lifestyle. And the one agent that actually works is amitriptyline. She found that switching from paracetamol to naproxen also helped acute treatment of some of those headaches. But she had a bit of a problem increasing the end dose. Sometimes it made her too sleepy. We had to bring the dose again close to 5 p.m. We had to change her shift profile. I had to write a letter to say, look, she can't work night shifts because we can't administer the medications in a sensible way. She put on a bit of weight. And then once the work pattern changed and she got out of night shifts, she managed to pull herself together, adopted a healthy diet, and over about a year started exercising and getting her lifestyle together. It took a dose of about 75 milligrams of amitriptyline at night for a period of several months to get her headaches under control. Even then, the headaches didn't vanish, but they became episodic and they were occurring about once or twice and very mildly, as opposed to every day and all the time. So it changed from a chronic headache to an episodic headache. So these are the criteria for tension headache, usually bilateral, criterion 1. Pressing or vice-like, mild to moderate, not severe, not aggravated by physical activity. Usually, you wouldn't have more than one of the above: photophobia, phonophobia, or nausea. Okay, but the key thing is the quality of it and the duration and the very gentle intensity. Many things work for this, but it takes an eternity to get on top of your treatment. At the moment, I'm battling with yet another colleague who's been undergoing treatment for about 6 months. We've tried all of the above: simple analgesics, scalp, neck massage. He's very resistant to cognitive therapies or trialing non-medication related therapies. And certainly tricyclic antidepressants do help, as does venlafaxine. So any questions about tension headache?
So there's no question on tension headache, but there is some mentioned the patient with a history of both migraine and trigeminal neuralgia. What would be the best medication for that patient?
Okay, so as you know, for the neuralgiform headaches, the medications that tend to work are carbamazepine, oxcarbazepine, sodium valproate, and perhaps lamotrigine. So if I were to be treating this patient, I would probably choose, it depends on their profile, whether they're a skinny person, big person. I would have chosen sodium valproate or lamotrigine. I tend to like lamotrigine a lot because if you get past the 15% chance of a rash, it is really well tolerated and it really gives them a big mood pickup as well. So I would have picked lamotrigine. Would have started at about 12.5 milligrams BD and slowly increased to 25 BD, then 25, 50, 50, 50, and so forth. You're allowed a dose increase every fortnight, but the key is to start super slow, so really half a tablet BD. So those are the two drugs I would have chosen. Of course, if the one is dominating over the other, I would have picked the one. So if the migraine is the bigger problem, I would have picked to prioritize the migraine and used whatever it is I think befits his profile. But if they are of equal importance, I think either lamotrigine or valproate.
Okay, so there's a question on the tension headache. So is there indication for MRI for tension headaches or for a young patient with frequent headaches, I suppose?
Look, if it is the very first time, I would do a non-urgent headache, not non-urgent MRI. Yeah, I wouldn't be rushing into it, but I would do just once in the lifetime of the patient. Yeah.
Okay. Does hypertension cause headaches?
Have seen hypertensive encephalopathy presenting with headache. It's a rare thing. In theory, I'd say yes, but if you mean not the hypertensive encephalopathy, but hypertension, I don't know is the answer. In theory, yes. I haven't seen it. I have, however, seen hypertension giving people brain fog, where I've measured their blood pressure. It's very high. They have this non-specific dizziness. I measured the blood pressure expecting a postural drop or hypotension. Then the GP took over from me and did a few more consecutive measures, and it's still high. And the blood pressure was treated and the brain fog goes away. So I do see that, but I don't know whether I haven't encountered just the common garden variety of hypertension presenting with headache.
Okay. Now we have passed a lot of time. Is there anything you want to sum up or as a take-home message?
I will go to my last slide. There are a few cases. Oh, I'll do my red flags. Okay. Red flags for secondary headaches. Sudden severe equals subarachnoid, worsening pattern, space-occupying lesion, unusual aura, the one that one of the colleagues was talking about, long aura. I always worry about, is there an undiagnosed arteriovenous malformation? Cough, valsalva or laughing headache, space-occupying lesion or Chiari. And then a new headache or a more prolonged headache than usual. Severe new headaches in pregnancy or postpartum. Got to think of venous sinus thrombosis. So those are the kind of indications for urgent imaging. Naturally, orthostatic headaches would indicate a CSF leak. Anyone with cancer or HIV will score imaging very easily because bad things can happen to these people. Should not forget people with obesity and fatigue and wake-up headache, obstructive sleep apnea being the cause. Older people with any headache should be highly suspect for giant cell arteritis and would require an ESR and a good palpation of the temporal arteries. Take-home messages, the key thing is to identify the syndrome. Is it a primary headache? Is it a secondary headache? Is it migraine? Is it tension type? And those are the two major types that you and I will have to contend with. Do have a look through the slides of the trigeminal autonomic headaches. These are the ones that have the tearing and the runny nose, and they are very responsive to drugs like carbamazepine, lamotrigine, and also responsive to indomethacin. Really important to offer them the three kinds of treatment: a rescue drug, lifestyle adjustments, and a specific therapy, which is a maintenance drug or a maintenance natural product. It's important to let them know that there won't be a magic pill. We will be reducing the frequency rather than offering a cure. Thank you so much. Now, this is my headache trigger at home. The little one is Tigger and the big one is Daisy. and they're my biggest source of headaches.
Absolutely gorgeous.
Thank you so much for the time.